Good morning. My name is Gabriela Milla-Godoy. I'm a resident physician at Metro West Medical Center in Framingham, Massachusetts, and it is my pleasure to present our quality improvement project, which is changing the culture around urine cultures. As an introduction, asymptomatic bacteriuria is defined as the presence of 10 to the 5 colony-forming units of a bacteria present in the urine of a sample on a patient without genitourinary symptoms. Screening and treatment of asymptomatic bacteriuria is recommended on certain patient populations such as pregnancy and also patients undergoing urological procedures with mucosal trauma. Screening and treating patients other than this population group often leads to treatment, and treatment leads to consequences such as C. difficile infection, antibiotic adverse reactions, and development of multi-drug resistant organisms. Therefore, we develop an algorithm with an educational campaign and direct feedback with the intention to decrease the number of urine cultures and as well decreasing the number of patients treated for asymptomatic bacteriuria. Our methods included, we retrospectively reviewed the pre-intervention group from September to October 2019, and we did an educational campaign including 5-minute morning talks, development and distribution of a decision tree algorithm from November to December 2019, and then afterwards we did a post-intervention group and reviewed the urine samples and charts from January to February 2020. Our educational algorithm is detailed below, where we would ask the question, does your patient have a Foley? And if the question was yes, we would ask for questions of symptoms tailored to urinary tract infection. And if the patient didn't have any of this, we would not recommend obtaining a urine culture, but if the patient did, we would recommend to change the Foley first, send UA, and then for culture. If the patient did not have a Foley catheter, we would ask the following questions. Does your patient have dysuria, frequency, or suprapubic or pelvic pain? If the answer was yes, we would recommend the same: to obtain a clean catch urine, send for UA. If more than 10, send for culture. And if no, we would not recommend to send for UA and culture. And if the patient had a fever, we would recommend to exclude other causes other than urinary tract infection. And so our results are detailed here and also in these tables. So we can see that a total of 486 urine cultures were analyzed with a mean age of 59, 67% were female. The majority of cultures, it is notable to highlight that they were obtained in the emergency department with 89.5%. In the asymptomatic patients, 48.9 were ordered in the pre-intervention group and 51% in the post-intervention group with a p-value of 0.666. And in the ones with asymptomatic bacteriuria, 14.4 were treated versus 17.4 in the post-intervention group with a p-value of 0.62. Average duration of antibiotic days was 5.4 versus 6.1 days respectively. And so our conclusion, this focused 2-month period of the educational campaign did not yield a statistically clinical difference in number of urine cultures. However, it demonstrated the challenges in laboratory antimicrobial stewardship among busy clinicians, and that given that the urine cultures were obtained at the emergency department, our ED clinicians can be the target audience for urine culture stewardship. And therefore, the current challenges requires a multifaceted interdisciplinary antimicrobial and laboratory stewardship approaches. Thank you very much.